right, welcome back, everyone. Mhm. Hello.
Good morning.
So everybody, I want to make just a quick introduction. Our first conversation today is going to be with Dr. Peter Rowe. We are so lucky to be joined by a world-renowned physician with over 30 years of experience treating patients with chronic illnesses, including ME/CFS, dysautonomia, and related illnesses. Now, importantly, including long COVID. Since 1996, Dr. Rowe has served as the director of the Johns Hopkins Children's Center Chronic Fatigue Clinic in Baltimore, Maryland. Thank you so much, Dr. Rowe, for taking time on your Saturday to be here with us.
My pleasure, Ella. Happy to join you.
Thank you.
Keeps me from having to mow the lawn.
Sorry?
It keeps me from having to mow the lawn.
Well, we'll have you more often then. Your grass will get quite long. Well, again, I truly appreciate it. I would imagine that so many of our attendees are familiar with your work because of the groundbreaking nature of the research you've done over the course of your multiple decade career. And so many of us have benefited from that. But for those of our attendees and viewers that are not quite familiar, do you mind giving us an introduction to your career in medicine and how it's related to our community?
Sure. So I started off with general pediatrics training and some clinical research training and fellowship, but was always sort of drawn towards the clinical problems and worked as kind of a consultant to other pediatricians. And when I returned from Canada to Baltimore in 1991, I was running the Diagnostic Problems Clinic. So we would see patients with all kinds of poorly sorted out complaints and symptoms. And some of them included kids with chronic fatigue syndrome. And around that time, the received wisdom was that this was all a psychosomatic disorder. It was mostly women. It was mostly people from upper middle class backgrounds, it was thought, and nobody could find anything wrong on the physical exam. So they must be making it up. And when I started looking at these kids, I thought they all look kind of pale. Their legs are sort of purple. They looked sick. And what was unlike a psychosomatic disorder is they were giving me a monotonously similar group of symptoms. So it wasn't scattered to the winds. It was the same group of symptoms: fatigue, lightheadedness, trouble in the heat. And so we thought, this looks like people with recurrent syncope, fainting. So I approached our colleague, Hugh Calkins, who ran the tilt table testing lab. And I said, Hugh, I think this is similar to what the fainters have. We put them on the tilt table and their blood pressure just plummeted like a stone, and we could reproduce their typical daily symptoms on the tilt table. We thought, well, let's try treating them with what you use for recurrent fainting, and a certain proportion got better. And so that was the start of shifting my clinical focus away from the just generalized problems to the folks who had chronic fatigue syndrome, because the first paper we published in the Lancet was simply a seven patient case series showing that they all got symptomatic on the tilt table. They all became hypotensive, and 4 of the 7 improved substantially. And it really started the concept that orthostatic intolerance of upright posture, was really a big factor in these illnesses. We got 5,000 phone calls the next week asking us to see patients. And I realized this was a tremendous unmet need in the population. We published another paper using both adolescents and adults and some healthy controls. About 5 months later, same thing happened. We had to hire a public relations firm to handle all the requests. And from that point on, I thought, this is a really interesting problem. People are desperate. They're really pretty sick. And we just have kept trying to find other clinical clues to what's provoking their symptoms.
Wow, that's amazing. Yeah, something that many people probably take for granted now that connection between, ME/CFS and autonomic dysfunction and other things. Um, and I'm wondering, your research in this area has had a significant impact on the understanding of ME/CFS and its related disorders. Um, and remind me, what year was this that this was discovered?
So we started doing the tilt testing in about 1993, and the papers came out in 1995. And
Okay.
at the time, people were saying, "Well, you're shifting people away from what we should be dealing with in chronic fatigue syndrome, which was hunting for the virus." Everybody thought there was a single agent that was responsible for it. That's proven to not be the case. And I think it took some time for people to realize this was an important pathophysiologic underpinning of symptoms, but also it is one of the most treatable forms of the illness. So I think you're right. Like we often joke that grandma knows this now, but it was a new concept back then.
Yeah. So you mentioned that it's the treatable portion of the illness. Can you just quickly touch on the recommendations that you make to patients that are experiencing these symptoms to treat that portion of their illness?
Yeah, so it starts with non-pharmacologic recommendations. The foundation has to be that you've got to drink at least 2 liters of fluid a day for most adolescents and young adults. You want to really bump up sodium intake according to taste, supplemented by salt tablets or electrolyte drinks. And then pretty soon after that, like that's usually not sufficient for treating most of the people who have true ME/CFS, right? It's not that mild an illness. And so we then go on to picking from 3 major categories of medications. One is drugs that improve the ability of vessels to constrict so that you're not leaving as much blood down in the lower half of the body as might happen otherwise. The second category is drugs that improve blood volume, because if you've got more back in the heart when you're standing, you've got more to pump up to the brain. And the third are drugs that control the excessive release of epinephrine and norepinephrine and can cause problems with heart rate and other symptoms. So those are in the first category, vasoconstrictors, we've got midodrine, we've got stimulant medications. The blood volume expanders are things like Florinef, fludrocortisone. Sometimes drugs like clonidine can do that, desmopressin. And then the mainstays of drugs that can help control heart rate and the catecholamine release are things like beta blockers. We use a lot of pyridostigmine bromide, and then a newer drug, ivabradine. And there's some drugs that cross several categories, like the SSRI and SNRI drugs that are usually used for depression and anxiety, but they can sometimes help with vessel constriction and maybe some of the brain-related sympathetic nervous system outflow that is increased in these situations.
Yeah. And you said the first line is non-pharmacological treatment. And so you see how, the patient responds to that intervention first, and it sounds like it's a stepwise process.
Yeah, although we move pretty quickly from the non-pharmacologic things because they don't usually help by themselves. We try also to get people to use different postures. So if you're sitting in a certain way or standing with your legs crossed, you're using your leg muscles as a way of pumping blood that would otherwise pool in the lower half of the body back up to the heart. So shifting your weight when you stand. Standing in what's called a cocktail party stance, where your legs are crossed over. Those can help. Compression garments can help some people, but not everyone tolerates them. You can kind of compress the vessels from the outside using body shaper garments that go from the upper abdomen to the lower thigh, or compression stockings. Sometimes they're a bit hot in the summertime, so not everybody likes those. And I think I've gone hoarse trying to recommend this to the support stockings to teenagers.
Yeah. It's a challenging transition, especially during the summer, but having to wear shorts and compression stockings, or, I've heard a lot about the pushback from that population in particular. But we're seeing this, you know, what percentage do you think of patients that end up developing this, are starting to see symptoms early in life, and so they'd be able to come see you in your clinic?
You mean how many are getting ME/CFS early in life?
Yeah, yeah.
Yeah, there's a peak. We usually don't see much orthostatic intolerance or ME/CFS under the age of 10. It can occur, but I teach our trainees that if you're seeing it under the age of 10, look for some other condition that might be driving the process.
Okay.
There seems to be something about the onset of pubertal growth or hormonal change that triggers the onset of illness. It may also require an infectious agent, such as something like mononucleosis, which is more likely to be present in teenagers. But something about that 10 to 19-year-old period is a common time for onset. With ME/CFS, it's thought that there are two general peaks in onset, one between 10 and 19 and the other between 30 and 39. You can get it all the way through life, but it isn't something that keeps getting more common the older you get. It's not a disorder of aging.
Yeah. Okay.
I can say thankfully so.
Yeah. So you're taking, multiple steps and checking in with patients longitudinally. Can you talk a little bit about your relationship with your patients? And, it's somewhat specific to the type of clinic that you are working in, that you're able to see patients longitudinally and get enough time with them, which is a whole nother discussion. But can you talk about your experience with this patient population, watching them grow and seeing changes over time?
Yeah, I think we try and bring people back monthly or every other month in the beginning as we're getting them settled and into a proper treatment regimen. Because in addition to the treatment of the dysautonomia piece, we find that about 30% of our patients have a milk protein hypersensitivity, where they have upper abdominal pain, reflux, early satiety, and removing milk from the diet, if they have those symptoms, is a critical piece, because if they're still ingesting something that's making them sick, it really obscures whatever benefit you're getting from a medication. We found that about 80% of our patients have some kind of myofascial tightness or adverse neural tension that is not typically picked up well by physicians, but can be addressed by really talented physical therapists. Clearing out these areas of tightness is important. We look carefully for neurologic exam abnormalities, because there are a subset of patients who have a neuroanatomic compression. And then something like 60% of our patients have joint hypermobility, which then contributes to their movement restrictions and areas of focal tightness. So we're constantly trying to peel away different aspects of the illness and treat each piece of it. And so we get to know these patients pretty well. One of the things that used to be said was that, again, by the people who misunderstood the illness as psychosomatic, is that these were patients that didn't want to get on with life or schooling. And there's nothing that could be further from the truth. Our patients want to be back in their, the same activities they used to participate in. I've not seen anyone wanting to remain ill. So I think one of the lessons of following people over time is you get to see what they're made of. You see the kind of grit that many of our patients have. And I've said many times, I hope that I will be as tough as some of these young people we've treated over the years if I get the same illness. We haven't seen people amplifying their symptoms or trying to get out of stuff. And once they feel better and can be active physically again, the phone goes dead. They're not kind of making up new things for us to treat. It's really lovely to see. And some of the best moments occur, like 2 weeks ago, when one of the patients that we were treating when she was a teenager, now she's in her mid-30s, and she brought her 9-month-old in to show us and she didn't need to talk about medicine. She wanted to show us her baby. And, that's a really gratifying time in medicine.
Yeah, that's amazing. Getting to see people develop into adults and, as they improve, getting to explore the things that they really love. And I'm sure that you have made such an impact on so many lives. The extent to which patients with this illness, I hesitate to use the word suffer, but I do think that there is, a battle with suffering with these illnesses. They need somebody that they feel like listen to them and believe them. And it's unfortunate, but I think there is a lot of rhetoric about there not being enough providers that are able to fulfill that need. But that time in life as teenagers, it's incredibly challenging to begin with, and being set back, doesn't help at all.
Yeah, no, and I think, one of the pieces of advice that many of us in this field give to other clinicians is, first of all, believe what you're hearing. Believe that the patient is telling you what is going on with them. If you don't understand it, that's one thing, but they are not trying to fool you. They are trying to express what's going on with them. And unfortunately, many of the patients we've seen who've been sick for a couple of years and seen other providers have had some medical trauma where people said, I don't think this is real. I think you're making this up. Or they've had, they've had some kind of setback that was induced by kind of people who are a bit too blunt or incorrect in their assessments. And so I think we find that once you start listening to them, their guard will go down if they've had some prior trauma, and they start realizing our job is to help them understand what's going on in a way that helps them get better.
Yeah. So if patients are either receiving pushback or disbelief in what they're sharing with physicians, I'm sure, I don't want to speak for you, but this is something that we've talked about in the past, that you've also received not so positive commentary from other providers that maybe aren't as informed on these illnesses and haven't been exposed to the evidence that, there are physiological explanations for these symptoms. Do you mind talking about that and how, your interactions with other providers have gone over the years?
Yeah, I think early on people thought, we're not seeing anything on the physical examination, but over time you can really elicit all sorts of problems with this purple discoloration of the limbs when people are standing. Acrocyanosis is the formal term. That's present in about 75% of people. They have delayed capillary refill. They have these heart rate and blood pressure abnormalities in like 96 to 100% of the adolescents. The joint hypermobility is visible. The child can't fake that. And so, we've had to, I think as we've shown this accumulation of objective physical findings, there is less skepticism. I think also the occurrence of ME/CFS after COVID has also changed the dialogue, because people have been so aware of how devastating COVID can be. So if it can lead to this illness, then maybe we were wrong in thinking that it wasn't much before. So I think there's been some change, but I'll tell you a sort of funny story. When we first submitted our paper in 1999 on the connection between CFS, Ehlers-Danlos syndrome, and orthostatic intolerance, that was one of my favorite papers, because up until that point, people who were flexible with Ehlers-Danlos syndrome and either joint pain or a lot of fatigue, the fatigue was attributed to the genetic syndrome and not thought to be a treatable phenomenon. When we started saying, no, you can treat the orthostatic intolerance and their fatigue should improve, that kind of changed the game in the Ehlers-Danlos syndrome community. But we sent the first paper into the Journal of the American Medical Association, And we got back a review from a kind of churlish medical reviewer who said, this is yet another piece of propaganda from the Johns Hopkins group that will lead to unnecessary testing, labeling, and treatment. And they rejected the paper. It fortunately got a home in the Journal of Pediatrics. And I think this is another one where your grandmother knows that joint hypermobility is now associated with orthostatic intolerance and that we can treat the fatigue. So it was the accumulation of data that really buried that churlish reviewer's attitude, or maybe he still has that attitude, but you can't really argue with the facts that have accumulated over time about that connection.
Yeah. So, you've been ahead of your time in terms of believing and, discovering these connections. Can you elaborate on any recent breakthroughs or findings that you believe can hold some promise for improving the lives of these patients with these conditions?
Yeah, we've been working this summer on something. It's an extension of what we had described before. One of the things that we learned in working with our physical therapy colleagues is we don't push people to be engaged in exercise-based physical therapy. They have to get all the areas of tightness cleared out first. And what we noticed in the beginning was that they would come back from their first assessment where all that was being done was range of motion testing. And they'd say the next day or the day after, am I supposed to be this tired just after a physical examination? And we were intrigued by that because if what the physical therapist was doing was provoking fatigue, we knew that over time their treatments were alleviating the fatigue. So we started looking at this notion of a restricted range of motion, and our patients get much more symptomatic with simply raising their leg up or moving their arm in a certain position that puts strain on the nerves of the upper limb. And it's a very significant difference on the examination between CFS patients and controls. So we had published that a few years ago. We'd shown that if you just raise somebody's leg and hold it there for 15 minutes, you can provoke up to 24 hours, sometimes more, of increased symptoms. So something about putting a strain on the nerves can provoke symptoms. That seems to me to be a really important observation that we ought to focus on. And we've seen it in long COVID as well. So this summer, we had a student, Charlie Edwards, join us. He's a rising senior at Vanderbilt. And Charlie wanted to work on a project. So we had him look through our records at all of the patients who had reported trouble with their arms overhead. So we'll often hear from especially young women that when they're shampooing their hair, their arms get really fatigued, they get numbness and tingling. I don't have that problem because my hair shampooing doesn't take very long. But a lot of the kids would report that, or they'd have trouble putting things away on a high shelf, or even hanging ornaments on the Christmas tree. Or with arms extended, you're supposed to hold your arms up like that on the steering wheel. They can't do it. They have to have their arm at the bottom of the steering wheel. So we started doing a test that's used for something called thoracic outlet syndrome, where nerves are being compressed as they go down into the arms. And it's simply a test in a candlestick position where they hold their arms up like this and open and close the fists. And the normal test lasts 3 minutes. We did it for only a minute. But that was enough to provoke arm fatigue, numbness, tingling in 95% of our CFS patients.
Wow.
Who had reported problems with their arms overhead. And what was new and interesting was that this also provoked systemic fatigue, brain fog, lightheadedness, symptoms that have never been reported in the thoracic outlet syndrome literature. So we think this is yet another area for physical therapists and clinicians to target in getting at the underlying biomechanical cause of their fatigue. So there's just a lot more now that we can use to treat patients effectively than was present in the past. The other area that I think has been fascinating is the area of allergic inflammation triggered by mast cell activation. Mast cells are important in responding to infections and allergens. but they can become sort of indiscriminate dumpers of histamine and other contents that can cause orthostatic intolerance, pain. And we recognize these patients in part because they're very intolerant of multiple foods, multiple medications, and they often have a lot of facial flushing, redness, hives, that sort of thing. So mast cell activation is another treatable component of the problem, and it seems to be much more linked to long COVID as well. So it gives us another avenue for treating patients. And as you can imagine, when people ask, well, what's the one drug that you would use for ME/CFS or long COVID? We can't answer that question because each person is going to have a different thing that you need to address first.
Yeah, and this research is also, to me, it's really a testament to the smallest things that we often take for granted when healthy can be debilitating to others. It's like, raising my arms like this. I have thoracic outlet syndrome too, so that's something that definitely would trigger me. But
Imagine how fast you could have been in swimming if you didn't have that.
I know what a detriment. um, but there were times where I personally was asked, how are you so tired if you didn't do anything? And quote, anything was, what I was doing was, causing post-exertional malaise. Can you talk a little bit about, the other triggers that you see in patients and, what triggers their PEM?
Yeah, so this post-exertional flare-up of a variety of symptoms, not just fatigue, was initially thought just to occur after physical exercise. But then people realized, sometimes even studying for a test draws enough energy to provoke this problem. We noticed it after putting people on the tilt table where they'd be up at 70 degrees. And then if we didn't do anything after provoking hypotension and a lot of symptoms, they would be really unwell with PEM for about a week. We realized early in the process that if we tilt tested them, they were abnormal, then we gave them 2 liters of IV fluids, the PEM would not occur, and they'd feel better leaving the office than when they came in. So it really taught them a lesson about the importance of hydration.
Mm-hmm.
Since then, we've found that this biomechanical strain, straight leg raise or putting a strain on the peripheral nerves can also provoke PEM. So, you could be standing at a cocktail party, which is really doing nothing, but having a lot of physiologic stress. You could be in a position where you think you're resting, where you're in bed, leaning back against the pillows if the covers are tight and bending your ankles backwards, you're getting a neural strain while you think you're resting. And you could get PEM after that. So there are a variety of ways. And I think for patients, people have often been judgmental because they'll say, well, I saw you playing 2 or 3 innings in the family softball game yesterday. How come you're in bed today? So it looks like an inconsistency in behavior, but it's really the ease with which PEM can be provoked that we really ought to be focusing on.
Yeah. Wow. So many things that you have learned over the course of your career and have shared with so many of us that now benefit. I wanted to talk about the conference that you were recently on the planning committee for. So for those that don't know, the National Academy of Sciences hosted a conference toward a common research agenda in infection-associated chronic illnesses. Can you talk a little bit about the conference and your overarching takeaways from the research and discussions that took place there?
Yeah, so it turns out that there are a number of infections that can trigger prolonged symptoms. We know that that's the case with Epstein-Barr virus, and recently Epstein-Barr virus has even been linked to multiple sclerosis. So somehow it predisposes people to MS. Lyme disease can trigger a range of symptoms termed post-treatment Lyme disease that look a lot like ME/CFS. We know ME/CFS can occur after infection, especially in the COVID pandemic. And you can even see post-infectious fatigue syndromes after things like Ebola. So all of these illnesses typically are handled in silos, and we haven't had a meeting of the minds to look for common mechanisms across these different diseases. But the national academies and the sponsors of the meeting, which included the CDC, were very interested in seeing, if we could share data across the individual diagnoses. And I think that was important, just to begin the discussions, because the people who'd been working on long COVID hadn't necessarily heard what the long Lyme people were saying or the ME/CFS community. So there needs to be this cross-fertilization of ideas, concepts. I think in the infectious disease and immunology world, there's a lot more work that's been done with COVID, where people are looking for, does the virus persist in tissues? Do parts of the virus persist? Is that responsible for immune activation? Could that be part of what's going on in other illnesses? And I think it just started a really good discussion. I think everybody from each field felt like they had learned a lot at the conference. One of the fathers of one of my patients had said, just focusing on post-infectious illness may be a limitation, and we ought to think about that going forward, because what about the people who don't have a known infectious agent triggering their illness, but they get to the same endpoint? We used to think that maybe 40% of our patients had an insidious onset of the illness without a true infection. But I think what COVID has taught us is, if you had an asymptomatic something when it was not a pandemic and we didn't know to look for that infection, you couldn't ever prove what had started the illness. So maybe all of it's post-infectious, or maybe it's a heterogeneous mix, but we probably ought to include those patients in our studies as well.
Yeah, I think that, hopefully this leads to some sort of post-infectious specialty where, providers are able to take on patients with different illnesses that have caused them to reach similar points. But it is hard to get at the cause, which we've seen for decades. We may associate a certain virus with these outcomes, but we don't necessarily fully understand the pathophysiology of how patients present with the symptoms that they present. And
Yeah, I would say that one of the things that we need to do is connect the basic researchers with the clinical observations. So they have to help us understand, why do these illnesses result in so much autonomic and circulatory dysfunction? Like, what could be going on? And not just ignoring the clinical observations of the last few years. What does being hypermobile do in some way to your response to infection, or the way the vessels respond? All of these things. Are the mast cells activated by COVID or other infections to then perpetuate the illness? These are really good questions to ask that we couldn't even begin to ask 20 years ago.
yeah. And why do you think that we couldn't ask them 20 years ago because we had such a low level of understanding, or what is it that's changed?
I think there's a little bit of that, but also the accumulating of clinical observations about joint hypermobility, about orthostatic intolerance. Mast cell activation syndrome wasn't even described until about 2013, 2014. So most physicians weren't trained to even know what it was. And now we're recognizing it a lot in our population with these overlapping illnesses. And there's some evidence emerging that treating mast cell activation with antihistamines, including simple H1 antihistamines, but also the H2 blockers like famotidine or Pepcid, can have a role in treating prolonged long COVID symptoms. So there's a lot that's bubbling up that may end up tying these things together.
And do you feel like the conference was successful in proposing more research questions that need to be addressed? Do you feel like that was like a major takeaway?
I think so. I think we'll see. I think it will also, people were very eager to have follow-up conferences that allowed us to not, we had to limit the number of different post-infectious illnesses just because of the limited number of slots for speakers.
Mhm.
But there are other constituencies that would like to be included in this, including the PANDAS or PANS community, where you get neuropsychiatric illness after infections. So there's a much broader community of people with different post-infectious problems that probably need to be included.
Yeah. Well, thank you so much for your work in that area and always being such a great advocate for this community. I want to ask, we're going to spend the last 10 minutes of our discussion opening it up for questions for patients or caregivers or allies who are on today. So we just have a couple more minutes, and as a rising physician and many years I have left to train, I am wondering, if this is an area that medical students or other medical professionals are interested in exploring for their career. I would love to know if you have any advice on how to approach this patient population with humility and understanding, given that we don't have all the answers and it's not a clear-cut path.
I don't know if they hand this out to every junior medical student, but one of the articles I got as I started medical school was about uncertainty, and that medicine was an education in uncertainty, and that you had to somehow come to grips with a lot of the things that you were looking at you didn't know the answers to. And so it is important to remain humble, but also curious, open to new insights. And I like a quote from the American poet, William Carlos Williams, who was also a pediatrician. And one of his ideas was, out of dissonance comes discovery. So when we have things that are sort of in opposition, probably the reason they're in opposition, or ideas that are conflicting, is that we don't have enough data. And so it helps drive the questions to ask, like, why are all these young people coming in lightheaded and tired? Well, it's probably not a TikTok game. It's probably a real illness. So I think just keeping your mind open to what patients are saying. They are. It is extraordinarily rare for people to come in trying to fool us, or having some agenda like people used to talk about, Munchausen by proxy for the mothers, or Munchausen syndrome. That is as rare as hen's teeth. And what you're really seeing are people who are suffering and are trying to find a language to describe what's going on. Mast cell activation is an example. People used to come in saying, I'm allergic to these 15 drugs. And they would do the skin tests or the blood tests and prove that it was not an IgE-mediated allergy. But when they incubated those people's mast cells with the medicines they said they were allergic to, the mast cells degranulate. So they were describing a true phenomenon. They didn't know the right lingo to use, but instead of being disregarded and pushed away, now we've got a way of understanding what they were saying and treating them more effectively. And so I think avoiding a rush to judgment prematurely is important. There was also a paper, I pulled it out today because I thought this was relevant. This was called Skeptical of Skeptics. It was by a guy named Thomas English, who was a surgeon in North Carolina. And it was a one-piece paper in JAMA, where he said, skepticism permeates our profession. It's ingrained during medical training and reinforced by professional experience. Who among us has not repeatedly seen claims for fourth-generation drugs with no side effects, new operations that yield glowing results with minimal complications, or the latest infallible high-tech diagnostic procedure only to discover months or years later that these claims missed the truth by miles. Small wonder most of us are skeptics. To be skeptical is to be detached, rational, and objective. Skepticism is widely perceived as the prudent, conservative way to deal with ambiguous situations, times when even experts are confounded. Healthy skepticism is the in attitude for intelligent, discriminating physicians. But he said, but healthy for whom? And then he goes on to describe how he got chronic fatigue syndrome, and nothing could have been more devastating to him or to his career. And so it's a really nice thought piece that I think probably every medical student ought to read to remind themselves of how often we've been wrong in medicine. You know, think about MS being called the faker's disease. I still remember a time in medical school where the rheumatologist brought in a woman with lupus. And for a long time, lupus, we didn't have the ANA test for lupus. But what the blood test that would often turn positive was the cross-reacting antibody that suggested that people had syphilis. And this poor woman had been married in Scotland, developed lupus. The blood test suggested that she had syphilis. Her husband divorced her. Her family shunned her. She moved to Canada. And only later was the ANA test available to prove that there was nothing about syphilis in her history. So she'd been totally wronged. And that talk really stuck with me, that we have to avoid this rush to judgment and to be too skeptical of what people are saying.
Yeah. Wow. A beautiful piece and a really, really telling story. I'll definitely be keeping that in mind as I move forward, and all the other medical students that are listening. I hope they take that to heart. And I really appreciate your perspective on this, and all of the work that you've done also to educate so many students, in your work at Johns Hopkins, which I'm sure has had an influence on the way that they interact with their patients and practice medicine. So thank you.
Sure.
So we do have a couple questions in the Q&A. The first one I think would be good to touch on is from Brooke. She asked, what advice do you have for patients who are currently dealing with medical gaslighting and trauma, if at all? I know that, you're in a position and of the perspective of believing patients and supporting them. But if you have anything to touch on that question, that would be great.
Yeah, and I think this came up a bit at the National Academies Conference. And that was a plea that we devote a lot more resources to proper clinical care for people with these really common disorders. It's one thing to have a lot of research, but if there's nobody there to put it into practice or to manage the clinical manifestations for patients, people are going to remain disabled. And I think there's been a lot of frustration, especially in the long COVID clinic, but before that in the MECFS community, that there were too few clinics scattered around. In terms of how to deal with the medical gaslighting, I think part of it is educate yourself on things and remind yourself that you're not making this up, that these are non-random comorbid conditions, right? People have a group of things that occur together, not by chance. And if you're being disregarded, you can keep hunting for a physician who will be more supportive and thoughtful and listen better, recognizing that we're still at a staffing crisis for these illnesses. Making sure that you've got some help from psychological colleagues, people who can remind you often that this isn't something you're making up. And I think most of us think when there's no answer, maybe I am crazy. But I think you got to resist that temptation and just keep trying to find a more supportive group of clinicians.
Yeah.
I'll give you another example. There's another field that interacts with our group, especially the EDS patients. They often get early vascular disorders like varicose veins. Well, women who have varicose veins in the pelvis have something called pelvic congestion syndrome or pelvic venous insufficiency. What do they get? Well, they get low back pain, pelvic heaviness, urinary urgency, and pain with intercourse. And so in the 1940s, they were said to be emotionally frigid. Well, there's nothing emotionally frigid about them. It was just that their vessels were so dilated that it was really painful to even put in a tampon, let alone have intercourse. Nowadays, nobody would regard them as defective emotionally. They just move on to do the transcatheter embolization of these abnormal vessels and treat them. And we're finding that that's another area of effective therapy for these fatiguing illnesses. There needs to be way more work, but a number of people have been publishing nice new work on that lately.
Yeah. Yeah. Navigating this as a patient is definitely challenging, and really part of the reason that we created this community. Because, as you know, and everyone else knows, it takes a long time to often to get the right care. And we hope to be a bridge for people to at least have a community to connect with in the meantime. So hopefully, everyone listening can feel also that they have an expert sitting in front of them telling them that, they're not making this up, and to keep pushing forward to search for treatment and answers and rely on the resources that we do have in research. And another question, anonymous
Before you
question.
get to that, Ella, let me just make one comment. My wife and I went to a exhibit at the Museum of Modern Art in New York. They had a Georgia O'Keeffe exhibit of her early works, and the poster for it was one that resonated with me. And I'm just looking over at it. It says, "To see takes time." And that's both for patients to recognize how things might be interconnected, but also for us to see the things that are staring us in the face, but we don't recognize because we don't know what to look for. And I think there's going to be further evolution in this field as we pay more and more attention to the physical exam and the interconnectedness of all of these symptoms. But I like that line, "To see takes time."
Yeah, even to see for ourselves takes time. So do you have any recommendations for resources that you feel have or I guess are legitimate, that you recommend that patients, either dealing with ME/CFS or dysautonomia should go to if they're looking for research?
So I think some of the patient advocacy groups are really good. The Solve ME/CFS initiative, it used to be called the CFIDS Association of America. They've always been good providers of valid and up-to-date information. And they offer a variety of things that people can participate in the research. They have a biobank, they have these tracking apps that are then used by researchers. So they're a good source of information, but also they've been great advocates for better funding for that illness. In the EDS world, it's the Ehlers-Danlos Syndrome Society. They have really good conferences every year and very good talks. Their Chronic Pain Partners is another EDS group that has really good webinars on various aspects of the illness. Dysautonomia International has a conference each summer, and their talks are also usually very good. So there's a lot out there now that we can access electronically, and the availability of Zoom and other virtual talks means that this stuff is recorded on YouTube, and we have several webinars that we've done. There's one that we did back in 2010 on managing orthostatic intolerance, and that goes through the various medications if people want to look at that. You can find it by searching Google or searching YouTube for Dr. Peter Rowe. And the reason I mentioned the doctor part is if you just search for Peter Rowe, you get the guy who was the director of the film The Little Shop of Horrors, so which is what my colleagues think my clinic should be called. But anyway, lots of good information out there.
Yeah, well, I appreciate your sense of humor always. And our last question, going back to knowing what to look for. One of our other panelists actually had a quick question. Are there any simple tests that can be introduced early in the diagnostic process to reveal these types of illnesses, or at least point physicians in the right direction? Something that can help avoid often long and sometimes traumatic diagnoses.
Yes, I think, what we look for is on a full, physical exam and history, is there a substantial impairment in the things that person used to be able to do? Do they have unrefreshing sleep and post-exertional malaise? And are they unwell in positions of quiet upright posture? So we make sure the clinicians are asking about, how do you do if you're taking a hot shower? Do you have to sit down in the shower or lie down afterwards? How do you do in the mall? And my joke to the trainees is, if you've got an adolescent who can't go to the shopping mall and can't tolerate that, you've got an organic problem until proven otherwise. So you've got to ask specifically, because many times adolescents think everybody feels the way I feel. But so the history is important. The general group of lab tests we do are important for excluding other things. And then the couple of tests that I think are really critical. One is the 10-minute standing test, where we have people lying down for 5 minutes and then standing, leaning against the wall for 10, while we measure heart rate, blood pressure, and most importantly, symptom exacerbation. Because the average healthy person is simply bored when they're standing there for 10 minutes. Our patients feel really uncomfortable. And then if you don't have, one other thing that you could do is make sure people get evaluated by a good physical therapist who can look for these restrictions in range of motion that actually most physicians are not trained these days to pick up on. So you can get some supplementary help from the testing that physical therapists do, because they can help then advocate for that patient. This person's got a lot wrong.
Yeah. Wow. Well, so much advice and wisdom to take from our time together today. Dr. Rowe, I appreciate you spending the time on your weekend. I really do hope you got out of mowing the lawn. And thank your wife for allowing us to take some of your time. I truly appreciate all the work that you're doing for this community and the broader community. I know that so many of us have benefited from the research and all the hard work that you've put into your career. So
there's not much that's more gratifying than hearing that. So, thank you.
yeah. Well, thank you again for spending today with us. And we look forward to having or hearing more from you in the future. So yeah, we really, really appreciate it.
Good. Well, good luck with the rest of the conference. Thanks
Thank
again,
you.
Ella.
Take care.
Okay, bye.